Welcome back to the program, and from that cogent discussion there with the National Assembly Speaker Moses Wetangula, we now train our focus back to studio looking at health matters now. Our focus still centered on the burden of cancer, and this morning we focus largely on institutions looking at what they have done to alleviate the burden that is cancer. Dr. Alfred Karagu, who is the CEO, National Cancer Institute of Kenya, is our guest this morning, and he'll be helping us unpack all this in the next 60 minutes. Welcome to the program, Dr.
Thank you for having me.
Let's just start from understanding NCI, the National Cancer Institute. When was this organization formed, and what is its mandate?
Thank you very much, and good morning to all our viewers. The National Cancer Institute is a state corporation, is a government agency established under an Act of Parliament. The Act of Parliament, in this case, is the Cancer Prevention and Control Act, which was enacted back in 2012. So the Institute, in principle, came into being towards the end of 2015, early 2016, when the first Board of Trustees was inaugurated and a secretariat was put in place. So really the whole idea about having a National Cancer Institute is to have a central body or a government agency that is coordinating all issues to do with cancer prevention. And I think we must appreciate that cancer is a broad, area, is a broad disease that has very many elements that need to be addressed.
Yes, sure.
When you think about it, you must think about prevention, you must think about issues of screening and diagnosis, treatment. When you think about building capacity for cancer in terms of workforce, financing. So there are very many elements when you think about managing or addressing the burden of cancer that require deliberate action, that require resources to be placed against. So that's the whole essence why the institute was put in place. So the Act further then goes to assign some very specific functions to the institute. Broadly, the institute is supposed to be the policy advisory organ to the cabinet secretary. So on matters relating to cancer care, cancer prevention, cancer control, then the institute has that major responsibility of advising the cabinet secretary, who then develops policies on
so
what
the ones feeding the government.
We are feeding it to the government.
Okay.
But other than that, then we also have other technical roles that we're supposed to be performing. One of them is awareness creation. I think we must appreciate that information around cancer is in great demand, and it's not something that has been available historically. So we have that major responsibility of creating awareness about cancer as a disease. All those elements of what are the risk factors, what are the early signs and symptoms, but more importantly, on where services are available, because I think that's what the ordinary Kenyan would want to know. Where can I access these services?
Exactly.
So there's a lot of awareness creation around that. The other major function is on issues of what I may call regulation, or ensuring that the kind of care that is being provided in our hospitals, in our various institutions, is of the highest quality or adheres to various standards. So over time, we have actually expanded that mandate, and we are working very closely with the NHIF to make sure that, because NHIF, and probably I'm sure we'll probably touch on NHIF as in this discussion. NHIF is, I would say, one of the major player in terms of financing for health and specifically for cancer care. So working very closely with them, we have seen the need to ensure that the hospitals or the institutions that are being covered or being reimbursed for providing services for cancer care need to meet certain minimum standards. So over the past, I think that we are going into the second year now. Over the past 2 years or so, we have put in place a mechanism to make sure that any hospital that is cleared by NHIF to be providing cancer treatment meets some standards that we have set. And we worked very closely with our stakeholders, our practitioners, our subject matter experts to come up with some set of standards that everybody should adhere to meet. Yes. So that's why I said that mandate of quality assurance and regulation is also very critical. Another key mandate is the issue of data, managing data, just having a grasp of how big a burden is cancer in this country. And we have worked, very deliberately over the past 2-3 years to put in place a mechanism for our medical institutions and our medical providers to be able to report on cancer. When you look at the Act actually, under Section 20 and 21 of the Cancer Prevention and Control Act, obligates anybody in this country who's providing cancer care services, or particularly cancer treatment services, anybody who is providing diagnostic services, whenever they make that diagnosis, they need to notify us so that we as a country we're able to keep track of how big a burden is cancer in this country. So that function on managing our data is precisely maintaining the cancer registry. Is something that is upon us, and we have taken up quite actively.
Well said.
Yes, and then the other elements I will talk about, things like capacity building, so ensuring that our health workers or various stakeholders have the information, have the skills and knowledge. Plus, of course, working with stakeholders to ensure that I think at the core of our being is to ensure that access to care is really enhanced. Yes.
I mean, really quite a detailed, descriptive way of what NCI does.
Yes.
And I mean, this is also part of why we are here, to just understand some of what progress has been made so far. And we'll come to that momentarily, but also you've touched on the burden.
Yes.
And I want us to expound on that a bit. Right now, as we speak, we know that cancer is the third leading cause of death. This is after infectious diseases and cardiovascular. So also from your practice, how bad is this burden that is cancer?
Well, the figures that you've stated are actually correct. The cancer is the third leading cause of death. In terms of number of new cases, on average, every new year we end up diagnosing about 42,000 new cases. And out of this, or when you look at the number of deaths that we experience on a yearly basis, are upwards of 27,000. So already from that description, we see that there's quite a high proportion of mortality from those who are diagnosed with cancer. And I think the biggest concern is the profile or the nature in which most of these cases are diagnosed or detected, because you'll find that when you look at data from our registry, from Kenyatta National Hospital, we are still seeing most cases coming in at advanced stages. So when you look at the data, it's about 60 to 65% of cases will be either in stage 3 or stage 4. So that's why that could probably explain that proportion of high cases in terms of deaths. In terms of how those cases are distributed, our biggest burden is actually breast cancer. Breast cancer, which affects both men and women. And
it's actually the leading cause, specifically, cancer.
Yes, the number one cancer in Kenya is breast cancer. About 6,800 new cases.
That is annually?
That's annually, yes. So essentially, when you compare that against all the other cancers, breast cancer by itself contributes about 15 to 16% of, so almost you'd say that between 1 and 2 cases of cancer is breast cancer in this country.
But why is that? I mean, we have so many types of cancers. Why is breast cancer very key on?
Well, I think that is the high incidence of breast cancer is not just globally. Breast cancer is among the most commonly occurring cancers because of a number of associations that have been established between certain factors, largely of lifestyle, and causation of breast cancer. Things like obesity, certain foodstuffs, particularly foodstuffs that are rich in those what you call fats, those polysaturated fats. Of course, there's the input of hormonal. There's a hormonal, relationship between the hormones, particularly in women, estrogen, and causation of breast cancer. There's an element of genetics. So there are certain persons, because of their genetic makeup, who are more inclined to getting breast cancer. So it's a mixture of factors, but I wouldn't say that is only unique to Kenya. Globally, when you look at the cancer profile, breast cancer comes out, as the most common.
Yes. Because again of all those factors that you've talked about.
Yes.
And you've said that again, the biggest impediment is late screening.
Yes.
Why is this the problem? Because almost every month we have a certain cancer being marked in terms of awareness.
Very
Just
true.
in October, we talked about Breast Cancer Awareness Month.
Yes.
So why do we still have late screening?
I would say there is a disconnect between what you call knowledge, being informed, and taking action. I think that's where that's our biggest.
So largely information is coming out.
I think information is because people are aware, and this has actually been shown. Some of the surveys that have been done, even within the health sector, like what we call the demographic health survey, you will have people responding that they are aware of breast cancer, they have heard about breast cancer.
Yeah.
But when you ask the same question, out of the ones who are even aware of the breast cancer, how many have gone out for screening?
Yeah, just screening.
Yeah, just screening, then a very low proportion. So I think that's part of our initiative in terms of awareness creation, to demystify that concept. Because I think the number of factors that probably make people to shy away from, coming out for screening, things like when I'm screened and this is detected, then it's more or less a death sentence. The fear factor that needs to be addressed. And also I think also there's an element of people understanding that some of these cancers can actually be detected very early and at a point when you can get complete cure. If you look at developed world settings, their mortality rates from breast cancer are fairly low compared to ours, because they have put in place mechanisms for screening, things like mammography machines that are able to detect very small, almost microscopic tumors that can't even be felt, even when you touch your breast. And because of the populations in those settings having embraced this screening, technologies, they actually saved from death, because the very early form of cancer will be detected. They'll go through treatment and they'll have a very long disease-free survival rate. Yes.
Yeah. So then what are you doing as National Cancer Institute? Because you've already established the problem is not really quite the information. Much of it is out there. The problem is that actualizing what you already know.
Yes.
And this comes in terms of screening, because it comes out as the biggest impediment to remove or reduce the burden of cancer.
Yes.
What are you doing as NCI to bridge that disconnect?
Well, I would say that there are those elements that we are taking lead in, particularly the issue of awareness creation. We are very keen on letting Kenyans to be aware that these services are available. I think the first thing is for people to know that, because previously we have got questions coming in. Where can I access? Yeah, you're talking about screening, but where can we get these services? So we have been very deliberate to, first of all, pass information on where services are available. And we work with the line ministry, the Ministry of Health, which has over the past few years quite done a lot of investment around establishing the infrastructure for screening. Right now, across all our 47 counties, there's at least one mammography machine, which is the main equipment that detects breast cancer. So now the other approach now, since we, after informing Kenyans where these services are available, the next thing is to sort of use various platforms or various personalities to sort of influence some sort of behavior change, because one of this approach is actually using survivors, breast cancer survivors, those who have gone through the experience of having been screened, treated, and are living on their 10th year, 15th year, even after going through
at least reduce on that fear.
Yes, so that now that can address, so that people can see that you can actually get screened, be diagnosed and treated, and resume your normal life. So we are trying to use those different champions. So on one end you use survivors. We're also using people, influencers in society. You see, like influential leaders, religious leaders. Previously we have also, like in the last regime, we have worked very closely with even the County First Ladies Association, because those are influential persons in the society, so that when they speak to women, as I speak to them about other things in the social, the social world.
I can also touch on this one.
Yes, the importance of breast cancer screening.
All right.
Yes.
I want us to take a very quick breather, but when we come back, we'll be looking at the progress made. We also look at the role of NHIF. There's really quite a lot of conversations surrounding, the fund that is NHIF, with prospects of increasing that contribution, with prospects of waiting for what Parliament might approve and what this might portend for private hospitals and ultimately cancer patients altogether. But just as you marinate on that one, I want us to take a very quick breather. We circle back with the Dr. Alfred Karagu with more on this conversation, still training our focus on the cancer care in Kenya, as well as looking at the role of institutions in alleviating the burden of cancer. Time for that break. Stay with us. Exactly 13 minutes past the top of the hour. Still on Good Morning Kenya, we continue apace with our conversation, still holding court with my guest, that is Dr. Alfred Karagu, CEO, National Cancer Institute of Kenya. Dr. Karagu, before we went on break, we're talking about the accessibility of these facilities. And just recently, Kenyatta University set up a cancer center. I think it was opened late last year. But then one would ask, how accessible are these cancer facilities? Someone out there in the remote village, how do they access these cancer facilities?
Yes, as I said earlier, the issue of access to care is a major concern for us. And through the engagements we've had with the ministry, with the Cabinet Secretary and the entire Ministry of Health fraternity, we have been able to work together to streamline or to push the agenda of decentralizing cancer care services. About 5 years ago, I would say, Kenyatta National Hospital in the public sector was able to provide, some cancer care or some cancer treatment services. But working very closely with the, various stakeholders, as we speak now, we have had quite a bit of, expansion of access to the services. At the national level now, we have, in addition to Kenyatta National Hospital, you have Moi Teaching and Referral Hospital covering the Western region, and now the Kenyatta University Teaching and Referral Hospital, which is really being positioned to play that role as a center of excellence. There are very deliberate investments at Kenyatta University Teaching and Referral Hospital to make sure that the highest quality of care can be accessed at the public health system. Yeah. In addition to that, then, we have worked very closely with various counties, particularly those counties that were former provincial general hospitals, so that it's something what you'd call a hub and spoke model, or the parents who are the national hospitals supporting the children to come up. Yeah. So we've seen quite a bit of good work happening in the regional centers. So as we speak, we have about 11 of them spread across the country. We have cancer treatment centers. And I would first of all flag out 3: Mombasa, Nakuru, and Garissa, because these centers, in addition to providing, when you talk about cancer treatment, mainly there will be 3 main types of treatment. So you can either go through surgery to remove the part that has cancer. On many occasions, then you'll also need to receive some medications, what we call chemotherapy. And then finally, there's what we call radiotherapy, where you use radioactive rays to not sort of burn out, if I may use that word, to burn out the cancerous cells. So why I picked out the 3 is because one of our biggest problems over the years has been access to that machine, those radiotherapy machines. Back in the days, you'd find that there's only one machine in Kenyatta, so when it breaks down, then people have to really, people either go to the private sector or just have to wait for the machine to come up.
And even as you talk about Daktari, I'm thinking on top of my head, and this might really be a very big, ambitious plan. But yes, you talked about region, you touched on the Western region, coastal region. Yes. But I'm thinking, health, given it's a devolved function, why can't you even have these centers within the counties? Because, for instance, when you talk about Western regions, you have counties of Kakamega, Bungoma, Vihiga. So if it's situated in one county, what about the remaining counties around the region? Yes,
that question gets asked a lot. And when you look at cancer is a fairly specialized cancer treatments are a fairly specialized area. So we must, ultimately we could get there, but we must also align some of these investments with the existing capacity. Okay. Because that's the other thing that is important, because you could put machines in all the hospitals in this country, but then we have the human resource. Do you have the health workforce that is trained to manage those?
So there's an aspect of training.
Yes, the aspect of training, ensuring that we have the qualified workforce who can manage those centers. Right. That's why it has been a progressive, kind of investment. Okay. So, as I said, across the country, there are about 11 centers. So those 3 are the ones that are able to provide radiotherapy, because it's a highly specialized, service. But the others that are there, the likes of Kakamega, as you said, Kisumu, Nyeri, Embu, Meru, Machakos, they are able to provide the chemotherapy, which is a mode of treatment where you administer drugs. They are also able they have surgeons, so they're also able to provide surgical treatment. So I think the idea is what they can do. And then now we establish networks, those regional networks, so that if you are for instance, in the coastal part of the country, if you are doing your chemotherapy, your surgical treatment at your county level, for those patients who require then the radiotherapy, then now they can be referred to Mombasa. So that kind of resource sharing, because again, we must appreciate that both the capital investment, the money that is required to buy this equipment is quite a significant amount of investment. There's a similar investment that is required in terms of maintenance. So we must put all this into consideration in terms of, in terms of placing this equipment and technologies across the country. But I wouldn't say that would never be an eventuality. As we grow as a country, as we develop our capacity, I would not, it would not be unusual, or it would come that at some point then we have all these comprehensive centers being spread across all our counties. Yes.
Okay, well said. Now talk to me about the task force that was constituted by the Ministry of Health to look into some of these cancer issues. I also understand that these findings were presented to the former Cabinet Secretary of Health, Mutahi Kagwe. What exactly were you looking into, and what findings came about from that, and as well as recommendations? Okay.
So the National Cancer Task Force was set up sometime back last year around the month of May, and went through its operations for about a year, and submitted its report to the outgoing Cabinet Secretary sometime in July this year. The whole idea about having the task force, I think when the Cabinet Secretary was putting together the task force, at the core of his mind was for us to answer the questions: why is cancer care not accessible in this country? Accessibility in terms of geographical accessibility, but more importantly, affordability. That was at the core of why can't we have. In fact, I think the question he sought to answer was, why do our Kenyans have to go to India to access cancer treatment and not, access it locally? Yes. So what are these bottlenecks? What are these gaps that are keeping us from getting to that status? So that was broadly the mandate of the task force. But of course, there were more specific things like understanding what is the status of what is the prevailing capacity to provide care. What are some of the institutional frameworks? How do various institutions work together to either coordinate issues of prevention, treatment, and so forth? So the task force. So in terms of there were very critical findings that came out. So probably I would just highlight on the major ones.
Yes.
Of course, the first one was the issue of financing for cancer care, and that's where NHIF comes in, because one of the key things that came out is NHIF has done its bit in terms of covering for cancer treatment, but what was very clear from the task force findings is that not much is being done. The current packages are not comprehensive. They are not because they only take care of certain components of treatment. So patients still have to go back to their pockets to cover for the remaining ones. In fact, it was unfortunate that in some instances, patients will be started on treatment because NHIF is covering, and when NHIF runs out, then they don't continue. So which is a wasted kind of treatment, if you may look at it that way. So financing issues was the issue of the role of NHIF and how it finances care came out very strongly. The issue of availability of services, particularly diagnostic services. As I said, I mentioned that quite a bit of work has been done in terms of setting up treatment centers. But before you go to treatment, it's important for you to go through screening and diagnosis. And for cancer, there's what you call pathology or biopsy, where you get a piece of the organ that has cancer. You know, get a sample of it, examine it under the microscope to confirm that actually this disease that we are dealing with is cancer. So that is one area that was felt that we found is a major gap in terms of those services that help us to confirm the diagnosis of cancer. As well, we found out that issues of the human resource, the workforce, there's quite a bit of shortage in terms of the various specialized personnel that we need to manage cancer in this country. Another critical finding was about just how services are organized, particularly at as you said previously, health is a devolved function. Yeah. So at the core of implementation are the counties. So what came out very strongly is that counties have not invested in, have not had some dedicated allocations of funds towards things like screening, towards things like capacity building, which are important.
And why is that? Because again, also there's been concern of funds really being domiciled mostly in the national government, yet health is a devolved function. Is this one of those biggest impediments to reduce this burden?
Yes. Well, I think there would be different reasons for different counties. Why different counties have not prioritized cancer per se. Right. When you engage with them, they will tell you that their biggest element in the health budget is paying for salaries for their health workforce. So the argument is that when they pay salaries, then what remains is being competed against many other elements. But for us who are driving this agenda, we still think that more can be done. And that brings me to the recommendations. There were very specific recommendations that came out of the report. And as an institute, as a secretariat at the National Cancer Institute, working very closely with our board of trustees. By the way, we have a new board that's about 2 or 3 months old right now. Came in July. Very vibrant, very progressive Kenyans who are helping us to think through issues of cancer. So together with them now, we have actually thought through a platform when we can have an opportunity for various stakeholders to come and discuss the recommendations of this task force. So we are working towards a national cancer summit. We have actually set up the 2nd to the 4th of February for stakeholders all over the country to convene in Nairobi for us to have discussions. By the time we get to that summit, we'll have crystallized, we'll have brought out the critical recommendations that are coming out from the report, so that we can now develop a common plan of action. How do we if I may speak to a few, there are issues of health workforce. Part of the recommendations was
part of that
from the report.
Okay.
The issues were coming out were we need to have a specific plan for training our health workers to become specialists in terms of managing oncology. So how do we go about that? There was an observation that we don't even have enough local training programs. So we bring on board the institutions of learning. How can we work together to put in place local training programs so that we move faster in terms of building the health workforce? Right. We'll have NHIF on board because issues of financing have come out. How do we make the NHIF cover more comprehensive? So what I'm trying to say is that we are very keen to ensure that the recommendations from this report don't just become a report that is in the shelves. So there's work that is ongoing. The next 2 weeks, we're actually having a media launch, more or less now, to start popularizing this summit so that Kenyans all over the country can become aware that there is this platform for us to collectively engage and come up with some very deliberate action points from this task force.
Okay, I hear you.
Yes.
I hear you.
Yes.
Now, let's stick on that NHIF bit just for a short while, because anytime you talk about chronic diseases, cancer being one of them, the question of NHIF never misses. Right now, we have proposals, particularly also from the president, to increase on this kitty, NHIF as well as NSSF.
Yes.
And this is just, again, for the purpose of assisting Kenyans in one way or the other. But just as you rightfully put, of course, it does not cover all through. For instance, I understand that even in private hospitals, whereby it's about 600,000 a year. So then what happens after that? Good number of these cancers don't end just within a year. So I want you to speak to the issue of increasing on this contribution vis-a-vis how it's currently working.
Well, definitely from the engagements we've had with the NHIF, some of the challenges that they face is the whole essence of inadequate financing. So like they feel that because of the many diseases that they have to cover, they cannot probably cover everything for all the diseases. And I think one of the biggest shortfall, or one of the biggest challenges is a concept they call adverse selection. What that means is that most Kenyans will enroll for NHIF when they fall sick. And as soon as we utilize the NHIF and access their treatment, then they fall back in terms of contribution. That goes against the whole concept of insurance, because insurance is the healthy take care of the sick. So you are making your contribution, and not necessarily because you'll use it, but because your contribution will cushion someone else. And so for me, I would look at I would not just focus on the increasing contribution, but I would even look at it more of the bigger concept is let us increase the net of contributors. So when we increase the net of contributors,
not putting the burden on one person to increase the contribution, but let's expand our pool.
Yes, the pool of contributors. And that is important because we can then, when we increase the pool from which the funds are coming through, then we are able now to expand the services. Currently, for instance, most screening services are not catered for under NHIF. So we want, as we bring in more into the pool, then we can expand the scope of services.
Now, so I see why people don't go for screening as well. You'd imagine.
But then you see the other thing that you asked me, how do I see this helping us?
Yes.
Some of the shortcomings that we have seen with NHIF is that they have sort of previously they have had a blanket package. So we said that chemotherapy is allocated this amount of money, but for different patients will have different treatment regimens. So there's that one patient who is allocated for purpose of discussion 600,000, but because of the nature of their regimen and the drug they're going to use, they're only going to use 150,000. So, but you see now that 600,000 was allocated to them. So it has been, if you have to say, it has been denied another person who may have used this balance of 450 to add to their 600 and end up completing their treatment. So the discussion we're having with them is, can we refocus the packages to be more focused on the treatment regimen that a patient requires, rather than just have a blanket, package that says, if you require chemotherapy, X amount of money. If you require radiotherapy, X amount of money. So those are the kind of discussions that we're having with them, so that ultimately the package ensures that the patient is taken to complete, to the completion of their journey in terms of treatment.
So then you don't undo whatever you've already done. Again, let's just stick on that NHIF bit just for a moment. And this is because there's that proposal to reduce on payouts still before Parliament. And the biggest question, and I'm so sure particularly for cancer patients, this is one of those biggest concerns. The minute or the moment Parliament approves this, then it simply means that for private hospitals, they wouldn't be accepting NHIF for these diseases. So not to say that they will approve, but in the moment this happens, what next for these patients in terms of treatment, seeing that this is the biggest burden of cancer?
Well, we are trying to think through a number of options.
And even what you're doing as an organization.
And even arising from some of these task force recommendations, we feel that one way of addressing this is ensuring that we strengthen services, particularly in the public sector. And not just treatment services, but ensure that all the way from screening to diagnosis and then to treatment. So it would be unfortunate that the payouts would be reduced, because that then would sort of reduce the incentives for because we must appreciate that both the public and private sector have a role in terms of providing health. They work hand in hand. So in the case of that eventuality, then because we exist because people pay taxes. We are a government agency. So now the next best option for us is to make sure that at least we have similar capacities within the public sector, so that part of those, a good proportion of those clients who miss out on the private sector can access the same facilities at the public sector. And by the way, we have started seeing
more like
shifts.
Revamping the public sector.
Yes. And a good example is Kenyatta University Teaching and Referral Hospital. There's a lot of shift in terms of access to cancer, specialized cancer treatment. People now shifting from the private sector to a facility that is within the public sector, just because this facility is well structured in terms of equipment, in terms of the workforce, in terms of the services that are being provided there. So we're using that example of KU Teaching and Referral Hospital. If the same is replicated in most of the other hospitals, then definitely that will go a long way in terms of addressing the shortcomings that would come from limited service availability at the private
and also
sector.
In the eventuality that this happens, at least it's a win-win and a balance at the end of the day. Also, talk to me about what you're doing as an organization in the aspect of socio-economic burden. Oftentimes when you touch on the issue of cancer, the burden is always again borne by the caregivers, the palliative care, so to speak. So what are you doing as NCI just to sort of like bridge that burden?
Yes, we are actually alive to that fact that cancer is not just about the medical treatment. There are others. There are the socio-economic.
It's a holistic.
Package. So we have picked up the element of what you call survivorship care. So when you have these people going through treatment and now they have survived through cancer and now they are being reintegrated in society, how can we, what can we do to help them in that journey? So currently what we are doing is that we are working with stakeholders to think through, to develop networks, because of course we must look at this holistically, because there are other initiatives happening in the bigger government, issues of small and micro, SMEs, and cooperative societies, and more or less the other sectors in government are trying to support groupings of Kenyans. So we are using that kind of approach to have networks of persons who have gone through cancer treatment, so that when they come together, when they collate and they form groups, then it's easy for them to lobby and leverage on some of the some of the existing opportunities. Well, the new administration now has come in with the upcoming Hustlers Fund. So you see, we are thinking, how then can we also link some of these survivor networks to benefit from this funding that is coming to persons who have formed these small enterprises. So really that what we are trying to trigger formation of networks of patients and cancer survivors, so that now they are well formed by the time now some of these opportunities are coming through. So it's all about working with various stakeholders to make that happen.
Okay, and very quickly, what is the survival rate? Well,
now that is a difficult question. Why I would say it's a difficult question is we have more than 200 types of cancers. So you'd have to talk about
each.
What is the survival rate for each of those 200?
Oh, so it's not cut across.
Yes, and so really what we talk about more is we use terminology like disease-free survival. So after you go through your treatment, how many, like if you start with 100 patients who are going through treatment, what percent of that is alive 5 years later, 10 years later and so forth. So we, as a country, I think we still don't have very solid data to show us those kinds of, of figures. But maybe what the closest we have applied is to comparing number of new cases at a singular point in time. What are the number of cases vis-a-vis the number of deaths from the same type of cancer? So that sort of gives you, it's not a very exact measure, but it gives you a sense of how well do people survive when they are diagnosed with this. So I would say when you look at some of the cancers, particularly breast cancer is among the more the better ones in terms of survival. But for some cancers like cancer of the esophagus, cancer of the liver, largely because they are detected late and also because they are very aggressive types of cancer. So you'll notice those differences.
So this again could be a very different conversation.
Yes. So I would say moving forward, those are some of the as we maintain our registry and as we analyze that data that comes to our registry, one of the things that we are very keen on is to start now documenting what our survival rates as Kenyans.
All right, I hear you. I mean, in 1.5 minutes as we exit this stage, Dr. Talk to me about where you see cancer care in the next 5 years or 6 years, for instance.
I honestly see better capacity. In fact, improved capacity for cancer care in this country.
All right.
I see a situation whereby Kenyans will be seeking treatment for cancer more in Kenya than outside Kenya because of some of the trajectory that we have taken.
Yeah.
I see a situation whereby Kenyans are more informed and hopefully more willing to take action in terms of their health-seeking behavior, in terms of going out there and being screened and being detected if they have cancers. I also see better capacity and a strengthened capacity both in terms of our health workforce, because as we develop local programs, then we envision a situation whereby we'll see lesser deficiency in terms of our specialized workforce and more research into what is driving cancer in this country.
Well said.
And those are the things I see.
I like that last part, more research, very important and key. I have been speaking to Dr. Alfred Karagu, CEO, National Cancer Institute of Kenya. Of course, what has formed center of our conversation is the cancer care in Kenya, as well as looking at the role of institutions in alleviating the burden of cancer. Good place to end this conversation, and ultimately, good morning, Kenya. Many thanks for joining us this Tuesday morning. Good morning. I'm Doreen Okello.